Respected senior respected senior dignitaries, directors, my fellow colleagues, a very good morning to all of you. Thank you so much for assembling at such early hours. Myself, Dr. Anubha, on behalf of Rajiv Gandhi Cancer Institute and Department of Critical Care, welcome you all to first of its kind, first Onco Critical Care Conference 2023. We hope that by end of this academic feast, all of us shall have a broader outlook and perspective towards critical care in oncology. So to set the stage right, I would like to request Dr. Praveen Kaur, Head Medical ICU and President of Onco Critical Care Society, to kindly address the gathering.
Thank you, Dr. Anubha. Good morning, everyone. Good morning, all my respected seniors, faculty members, and delegates. It gives me immense pleasure to welcome all the speakers and faculty members and delegates who have come here uh, to share their knowledge and vast experience with us. This conference in Onco Critical Care offers an excellent opportunity for delegates to engage with experts in the field. I will not take much of your time, so let us start this session, and I welcome you. I welcome all of you for this academic session. With this, let us start this program. Thank you so much.
Thank you, Dr. Praveen. So we begin with our first scientific session, and the topic is sepsis and cancer, an interplay of friends and foes. So to invite the chairpersons for the session on the stage, I would request Dr. Nitin Jain, Director and Head, Department of Critical Care, Paras Hospital, Gurgaon. Welcome, sir. Now I would request Dr. Manish Bharti, Senior Consultant and Intensivist at Sharda School of Medical Sciences and Research Center. Is also ISCCM President, Citation Awardee for 2022 and 23. Thank you, sir. Welcome.
Hello. Hello. Yeah. Good morning, everyone. First of all, I would like to say thank you and gratitude to the organizers for inviting us. And it is my proud privilege to introduce my teacher, my mentor, Dr. Rajesh Chawla. Dr. Rajesh Chawla, sir, he's head of the Department of Respiratory, Critical Care and Sleep Medicine at Indraprastha Apollo Hospital. He was the past president of Indian Society of Critical Care Medicine 2010 till 2012. He is also recipient of President's Citation Award, Society of Critical Care Medicine, USA. He's a founder, editor of Intensive Care Communication, the official monthly bulletin of ISCCM for 5 years. I welcome you, sir, on the behalf of first Onco Critical Care Conference 2023. Thank you.
Thank you, Dr. Manish. Good morning to everyone. And it's really a proud privilege that one of your students not only is the head critical care in Rajiv Gandhi, she's organizing the Congress, and not only organizing the Congress, she's made a society to really stress on the need of managing these patients, which is really, really very difficult. And the chairperson, Dr. Manish, is also our student. So it's really a privilege. One is organizing, the other is chairperson along with Dr. Nitin. So I'm going to talk. I think most of the time we spend in the ICU is dealing with sepsis. And now we're going to stress, is it little different in patients of cancer? You know, a lot of patients, they suffer from sepsis, and a lot of patients die annually because of sepsis. The moment I say sepsis, which is defined as life-threatening organ dysfunction due to dysregulated immune response to infection, 10% mortality. And if I say septic shock, 40% mortality. So these two modalities, once you say, you should be very careful in saying, because they carry mortality along with them. 15 to 20% of the patient admitted in the normal critical care units have hematological or solid malignancies. And they have about 20 to 40% mortality. And if they are from neutropenic sepsis, probably they have even higher mortality. And which is one of the main reason. And over the years, in spite of the advances in the management of sepsis, the mortality due to neutropenic sepsis is really not coming down. So now coming to my topic, sepsis and cancer. Why we are talking about and the name they have given, because they share number of pathophysiological and both result from inability of the host immune system to cope with the initial insult. Tissue invasion by pathogens in sepsis, and in the other there is a malignant cell transformation which multiplies. Immune dysfunctions which related to sepsis and cancer, they appear very similar because they both affect the innate as well as the adaptive immune cells, and they cause the profound alteration in the immune hemostasis, as well as the common existence of both disorders raise the question whether they have an impact on each other, which I'll discuss as we go along. The risk of sepsis and cancer is 10 times as compared to other individuals, particularly hematological malignancy, acute leukemia, and lymphoma. These are the commonest. They get admitted into critical ICU with sepsis. Solid tumors, lung, and GIT. These are the other group which get admitted with the sepsis. And as I said, they constitute about 15 to 20% of the patients. And if there sepsis and cancer, the mortality, as I said earlier, is higher in these patients. The other problem, that if it is a worsening of lymphoma or a worsening of leukemia or sepsis, it's sometimes extremely difficult because they mimic, because of the compression of the anatomic structures, tissue infiltration by tumor cells, release of intracellular metabolites by particular B-cell lymphoma and leukemias, danger-associated molecular patterns, cytokines from activated or dying malignant cells, hemophagocytic lymphohistiocytosis, which is also seen in the cancer patient, and coagulation abnormalities. Whether it is because of the disease, difficult to say. And you can have these symptoms: pleural effusion, pulmonary infiltration, intraalveolar hemorrhage because of the tumor, liver infiltration, cytokine storm, hypercalcemia, bone marrow infiltration leading on to DIC in these patients, and hyperphosphatemia, hypercalcemia, and hyperuricemia. And when you treat them, tumor lysis syndrome, they all look like sepsis. So sometimes it's really very difficult to differentiate whether it is worsening of the disease or it is a sepsis. Why the sepsis is higher in these patients? Because they are immunosuppressed, and the treatment you give also leads to commonly the neutropenia, another thing which predispose, and they have invasive procedures with long-term venous catheters, urinary catheters, and which predispose these patients to cancer. And the incidence, these are the sepsis, 9%. No longer we have a word severe sepsis, but it was about 53% in one of the studies. And gram-negative bacteria predominate, and multi-drug resistant bacteria, depending on your ICU, are also increasing in causing sepsis. Now let's understand that what exactly happens which is similar between sepsis and cancer. Whenever there is a agent, infective agents, there is an antigen present in cells, which is the macrophages, and it co-stimulates the CD4 cells. And when it stimulates, it releases the immunostimulant cytokines, which is IL-12, and which will activate CD4 cell, will stimulate, and will go on to cause the appropriate immune response. And the cytotoxic macrophages, B cell, neutrophils, they are recruited and they kill the bacteria or the agents. That's how the immune. So let's see in sepsis, what happens is, now all the three are blocked. There is impairment of all three signals. The first is the antigen presenting that within immune synapse, low expression of these molecules. And what happens is that IL-12 is not released. Rather, there is a checkpoint inhibitor, PDL1 and PD1, which are overexpressed, one on the antigen presenting cell, the other on the CD4 lymphocytes. And what it results? T cell exhaustion, And when there is a T cell exhaustion, these cytotoxic neutrophils and macrophages, they are not recruited, they are defective, and the sepsis occurs in these individuals. And in cancer, you have the impairment of all these three, that there is similar alteration as in sepsis within the immune synapse, thereby promoting the immune suppressive T regulatory responses. And as you can see, the PDL1 on the antigen presenting cell, PD1 checkpoint on the CD4 cell, and there is a IL-10. And again, there is a defective cytotoxicity, and it results in the increased tumor growth. So they have a similar kind of like you have in sepsis. Both cause immune alteration, both are friends, or you can say, now if you compare, they're almost similar kind of changes you see in sepsis and you see in cancer. A very interesting study. What they found that in mice model, what they did was they took mice, they first introduced into their peritoneum, they caused sepsis. 7 to 14 days, they inoculated the tumor. And what they found that there was a increase in the tumor growth. Then they said first cancer and then sepsis, let's see what happens. And then the cancer, they were pancreatic carcinoma cells were inoculated in the mice. And when they had a polymicrobial or the sepsis was introduced by causing peritonitis, there was a decrease in the tumor size. And now it is also said that probably people who had a sepsis earlier, they have more chances of getting cancer. Probably sepsis is a risk factor. And people who have tumor, if they get sepsis, there is decrease in the growth of tumor. So this is the in between the tumor, the cancer and sepsis relationship. Initially, when a person has a cancer, there is infectious insult. The CD8 cells and natural killer cell tumor suppressive, they inhibit the tumor growth. And then there is immunosuppressive macrophages, TREGs, and they accelerate the immune growth. And the numerous anti-cancer therapies which we give also cause changes and alter the immune response. The cancer treatment related alteration in the host defense occur. Cancer associated immune suppression is mostly related to treatment acquired immune dysfunctions, defective phagocytic activity, and phagocytic cells may sustain functional impairment in chemotaxis despite preserved circulatory counts. Counts may appear okay, but still may have a decreased phagocytic problems. So what are the problems in managing the sepsis and cancer? Early identification and diagnostics problem. You know, traditional diagnostic tests may not be very effective in detecting infection. Is these, particularly these people are, they have a lot of neutropenia. These are the, you should take a target history because it will tell you the site of infection which is resulting in sepsis. Then examination of these patients, the routine counts, and you must send a blood culture which is positive in about 40% of patients. And that's why the biomarkers, they are gaining a lot of importance in managing sepsis and cancer. The C-reactive protein and procalcitonin to differentiate whether it is a procalcitonin is probably more effective in differentiating whether it is a cancer problem or it is related to sepsis. Serum galactomannan for aspergillus 1,3-beta-D glucan is a broad spectrum in the blood which can give you the person has infection. It is a broad spectrum, positive in all fungi except in Cryptococcus and mucor. And then microbiological imaging tests which are appropriate to your patient. PCR or the BioFire is also gaining a lot of importance now with these MALDI-TOFs to give you results quickly and the particular species so that you can choose the antimicrobial quickly in these patients. So this is the history, risk assessment, protein tests, biomarkers, microbiology, and imaging. Then these patients have a high risk of complications and they have a varying causative agents which can cause disease in these individuals. So the optimal management of sepsis, including adequate and early source of control of infection, that's a basic about any sepsis. And as the time is passing, the more chances of the MDR pathogens are also prevalent because these people keep on coming to the hospital, get repeatedly admitted, and they colonize with the MDR bacteria. And when they get infection, they probably get infection with these individuals. And we are quite used to starting with a lower antibiotic. Probably they need the higher end antibiotic right from the beginning. Gram positive, gram negative, of course, are gaining more importance in these patients. This is a list which is, they can have viral, they can have bacterias of, and particularly, as I said, MDR. Now, Dr. Govil has the next talk. Probably there may be some overlap. And the organism which are in the non-neutropenic patients with sepsis and neutropenic sepsis, there is some difference. In one of the studies, they found that probably Klebsiella, Pseudomonas, they're more common in a neutropenic, and a non-neutropenic, the Enterococcus and the Staphylococcus, these are more common. But then they will depend on the epidemiology of this, the hospital, epidemiology of the colony, the patient, and the risk factor. A lot of these things also determine what is the etiology of organism in these. Overall, it is the gram negative which are predominating. We are not seeing that many gram positive. And the resistance among the gram negative, particularly the Klebsiella, E. coli, and carbapenem resistance is rising. Acidobacter, Pseudomonas, and all these have to be considered in cancer patient as well. And these are the various studies which have shown the rising trend of these infections in cancer patients. The risk factor for carbapenem resistant gram negative bacteria, this is a systematic review, and they found the previous antibiotic use, which is the most common risk factor for causing sepsis or the infection in these individuals. Previous carbapenem use is also one of the risk factors for carbapenem resistance. Previous colonization, because as I said, these patients keep on coming to the hospital, so they are colonized with these bacteria. That's why now that they are going on to the daycare, and patients are given in few hours and sent home quickly. Dialysis, catheter, length of stay, all these are risk factors in these individuals. And you have to choose the broad spectrum antibiotic based on your epidemiology, comorbidities, and the what is the basic treatment, previous treatment with which antibiotic he has taken. All these factors you take into account. So degree of immunocompromise, prior antibiotics, local pattern of antibiotic resistance, comorbidity, and microbiologic surveillance data from your hospital, and whether an agent is bactericidal or not, you should consider all this. And these are the drugs, cefepime, meropenem, impenem. Nowadays, we choose this along with aminoglycosides, fluoroquinolone, and if penicillin allergic to penicillin, then mesdopetam along with vancomycin or clindamycin, you can choose. And if you get a definitive answer, then these are the antibiotics which can be chosen for a specific microbe. And now there are BL-BLI combination which are available in difficult to treat, particularly the ceftidizine avibactam, which is coming along as the carbapenem resistance is rising. And the new ITSA guideline says that probably you should use less and less of polymyxin and go on to use these new BL-BLI combination, depending on what is the mechanism of carbapenem resistance. Duration of antibiotics, of course, minimum of about 10 to 14 days. And if it is neutropenic, till the count is more than 500. And at least 14 days if it is a neutropenic sepsis. And supportive care is same like in any intensive care patient. So I'll just give you again, which I started with, that any person who's got intrinsic factor, age, gender, ethnicity, genetic background, inherited immune deficiency, then the environmental factors like tobacco smoking, alcohol, diet, sun exposure, chemical radiation, and then acquired medical condition, immunosuppressive conditions and chronic, and over and above sepsis can lead to cancer. This is this is one of the risk factor because it will result in poly or oligoclonal immunostimulation, accelerated cell aging, defective epithelial healing, microbiota disruption, and sustained immune exhaustion. And this is the new concept which is being studied, that there is a relation, not only as a friend, but as an enemy also between sepsis and cancer. So to conclude, mortality has increased in sepsis if the cancer patient gets, improvement in the general management of sepsis, advances in cancer therapies, and improvement in the intensive care admission policy in recent decades has resulted in decreased mortality. But still, in some conditions, the mortality is still high. Early input must be sought from the critical care team, particularly when patients are hypotensive. Early use is associated with better outcomes, and good antimicrobial stewardship practices will be required. Thank you very much.
Excellent lecture, sir. Any questions from the audience? Sir, I have one question. In a non-neutropenic sepsis with septic shock in a malignancy patient, how early do you start empirical antifungals? If we have no evidence of
if suppose I got a procal and it is positive, then I would wait for a while because I know that it is bacterial. But many a times it depends on the response also. And there are various factors, whether your choice of antibiotic was proper. Suppose cancer with sepsis has arrived and this patient has been coming to the hospital repeatedly, and you started with carbapenem along with meropenem or along with some gram positive. Patient is not responding and he has a risk factor for carbapenem resistance. I would rather go for that first. But in sepsis, in malignancy patient, definitely you start the antifungal much early than in any other patient. Neutropenic sepsis, if they do not respond, then probably you will, after about 2 to 3 days, you start antifungal treatment. But non-neutropenic, it depends on what is your assessment about a patient. But there is no time that I would start like in a neutropenic patient.
Do we have the liberty to ask another question? Yes. Okay. Thank you, sir. Excellent presentation. I always enjoy your, the teaching. I just wanted to know your view on this part because I was going through the literature. The markers like procalcitonin and your CRP, they may not be very specific when it comes to the tumor care versus infection. This is what the literature is speaking. They were talking more about the novel markers like presepsin, adrenomedulin. So are we there, which we are coming up with this year?
Adrenomedulin is not available. They are saying that it is as good as procalcitonin, if not better. But, I tell you, normally I think a lot of senior intensivists are sitting, that you take the patient as a whole.
Yeah.
Because never take procalcitonin, even if it is high. It is not necessary that patient has definitely not responding. You have to take a patient as a whole. And many times, and there are a lot of false negative of procalcitonin in spite of the infection being present. But false positives are less comparatively. But you can have, so it is not that that you have to, if it is negative, you will not start the treatment. You take patient as a whole when you start treatment. So what is your view on this?
I completely agree with you, Dr. Chawla. In fact, the reason of asking you was because I wanted to have some new insights related to this topic. But I completely agree with you that the patient has to be taken in toto. So taking a decision just solely on the basis of one of the biomarker is too much, especially when the patient is having so many reasons, confounding variables as well. There's another thing which I wanted to know from you. You said in 40% of the cases, the patient will have blood culture which is going to be positive. let's say the 60% of the cases, they are not going to be positive. So what is your strategy in that cases? Again, you take always just clinical picture into the account for the antibiotic strategy.
Blood culture, even for non-neutropenic, any sepsis, the positivity depends on lot many factors. How many blood culture samples you send. If you send 2 to 3, the positivity rises. The amount of blood, they say if you want the fungal culture to be positive, it should be 30 or 40 ml. Nobody sends that much of amount in that blood culture. So there are many other factors which determine the positivity of a blood culture. But of course, you blood culture, if comes positive, it strengthens you, but it does not
It doesn't rule out.
take away my clinical sense of treating a patient.
That's important. Thank you, sir. Thank you for enlightening us. Thank you.
Thank you, sir. It was very informative. And I would now request Dr. Manish Bharti and Dr. Nitin to kindly felicitate Dr. Rajesh Chawla. I would now request our Director of Operations and Medical Superintendent, Dr. Pinky Yadav, to kindly felicitate our chairpersons. Dr. Brij Mohan. Thank you. Dr. Manish. Thank you so much, sir. Now, moving on to our next session, which is again a very important topic as far as cancer is concerned, neutropenic sepsis. So we request our chairpersons for the session, Dr. Sudha Kansal. Dr. Sudha Kansal is a senior consultant at Indraprastha Apollo Hospitals, and she has multiple publications and various journals and textbooks in her name. Her main interest in work is sepsis, ventilation, and acid-base disturbances. Welcome, ma'am.
Thank you.
We now have with us our second chairperson, Brij Mohan, Dr. Brij Mohan. He's associate consultant at Fortis Shalimar Bagh, New Delhi. Welcome, sir. Thank you, ma'am.
Yeah. Good morning, friends. At the outset, I'd like to congratulate Dr. Praveen for inception of this new society. It was really a need, so much cancer. We see almost 50% of patients admitted in ICU have cancers. And she's done just such a wonderful job. A big hand of applause for her. We are going on steps of Dr. Rajesh Chawla, who had so many societies and so many babies with her. You also have one. Now I'd like to introduce our next speaker, Dr. Deepak Govil. He doesn't need any introduction. All our ICU people and intensivists, they know him. But I still have to do it as a formality. Currently, he's a vice chairman, Critical Care Medicine, Institute of Critical Care and Anesthesia, Medanta, the Medicity, Gurgaon. He has all the possible affiliation with the Indian Society. He's been past president, Indian Society of Critical Care Medicine, past vice chancellor, Indian College of Critical Care Medicine, past controller of examination, Indian College of Critical Care Medicine. He's a director of Focus, ITO Delhi. One of the first society to make intensive care ultrasound so popular. And he's also a council member of World Federation of Intensive and Critical Care. Area of expertise are all, but mainly ventilation, hemodynamic monitoring, ultrasound and sepsis management. Dr. Deepak Govil, sir.
Oh, thank you, madam. Thank you, Madam Chairperson, for such illustrious introduction. First of all, I would like to thank Dr. Kaur and Dr. Das for presenting such a beautiful initiative and inviting me here. So I'm going to talk about the neutropenic sepsis, as Dr. Chawla has already set the stage rolling, in which we'll discuss some definitions. He has already covered few things, but probably might have some overlap. So what's neutropenia is defined as an absolute neutrophil count of 500 cells per cube or less than 1000 cells per cube, with an anticipated decline to less than 500 cells within 48 hours. And what's febrile neutropenia? Neutropenia with a single oral or tympanic temperature greater than or equal to 101 degree Fahrenheit, that equals to 38.3 degrees centigrade, or greater than or equal to 100.4 degree Fahrenheit or 38 degrees centigrade for at least 1 hour. So this difference is slight difference in the febrile definition. Then comes the sepsis. What do we mean by sepsis? Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to any infection. And septic shock we call when there is a subset of the sepsis where underlying circulatory, cellular, or metabolic abnormalities contribute to a greater risk of mortality than the posed by the sepsis alone. So we have to consider these two aspects as well while we are dealing with the neutropenic sepsis patients. Why the neutropenia is so important here? The neutrophil is a specific type of the white.
Dear dignitaries, directors, my fellow colleagues, a very good morning to all of you. Thank you so much for assembling at such early hours. Myself, Dr. Anubha, on behalf of Rajiv Gandhi Cancer Institute and Department of Critical Care, welcome you all to first of its kind, first Onco Critical Care Conference 2023. We hope that by end of this